Our next lecture is on adrenal insufficiency. You've talked about when there's too much aldosterone. We're done with that stuff, right? Let's talk about when there's no aldosterone at all, or there's no cortisol, even for that matter. So let's jump on this bagwag. Now, let's look at the name before we even move on. Adrenal insufficiency. Insufficient amount of something not being made by the adrenal gland. That makes it very easy for a definition. But the key thing is there's a primary cause. And when we say primary medicine, always look at the origin of the organ. We're talking about the adrenal gland. That's the primary site. Okay? This is the primary site. Something is wrong with the organ itself. If it's secondary, it's something second causing the problem. It could be coming from the pituitary gland. And we even have another fancy word for the tertiary. It could be coming from the hypothalamus. Okay? So, I need you to split your brain into two, but it's not actually that complicated. In primary, which we're just talking about, the organ itself, which is the adrenal gland, the first and the most common cause in industrialized world like America, Europe, right? Britain is autoimmune disease called Addison's disease. It's because you're making antibodies against what? The adrenal gland. They knock out the adrenal gland, cause chronic inflammation. They knock it out, and guess what? We can't make any cortisol or aldosterone. That's the most common in industrialized world. But in, not so industrialized worlds, in third world countries, guess what? TB, tuberculosis, infection is the most common cause of adrenal insufficiency. Tuberculosis is a nasty, nasty disease. People always think it's in the lungs. No, they can actually go into your kidneys and cause sterile pyuria. That's a little bit of my white blood cell. They can go into what? The adrenal gland. Not just again, after the liver, they can go into the adrenal gland and now cause adrenal insufficiency. They knock out the entire adrenal gland. They can met and go actually into the brain. TB is very nasty. It can go anywhere it wants. It can care less, right? On the other side, we can have an iatrogenic. It's a fancy word for the doctors did it. And what did we do? A bilateral adrenalectomy. If we went in there and took our both adrenal glands out, guess what? You're not going to be able to make anything. I just made you adrenal insufficient. That's right. Good job. Good job. I better replace those things that I took out. And we can have metastasis from either breast cancer or lung cancer into disrupting the entire gland itself. But that's primary. But by far is secondary. Even more common. Why? Everybody's on steroids. Right? Even your neighbor is on steroids. You might be on steroids, right? If you have asthma, we put you on steroids, right? You got lupus, you gotta be on steroids, right? You got any rheumatology problem, we put you on steroids. Leading me to COPD, steroids. Jeez, everyone is on steroids in America, right? So the most common cause is an abrupt cessation of steroid use. So if I put you on prednisone, right? And you're on prednisone, and you're taking it, and you're like, you know what? Screw that medicine, man. I'm gonna stop taking it. That is bad news. Because once you stop, what you don't realize is, if I keep giving you exogenous steroids, right? So you're taking the steroids I gave you and you're feeling good. And you're taking the little pill. Let's assume that's prednisone. And all of a sudden, what you don't realize is, since the adrenal gland is supposed to be producing a glucocorticoid called cortisol, but you already have steroids on board, it's going to stop producing cortisol because it's going to get a negative feedback mechanism to the adrenocorticotropic hormone, because it's going to like, you know what, don't waste your time. Pituitary gland, nah, somebody's already taking it. But the problem is the adrenal gland get used to it. They're like, well, guess what? I'm on vacation. Here's what's going to happen if I stop taking the steroids. All of a sudden, bam, I get trauma. I can't mount any stress response. Oh my goodness, my blood sugar is going to plop. And I'm going to go hypoglycemic because now cortisol, which is a stress hormone, can keep my blood pressure up. Get orthostatic hypotension. This is and they get susceptible to infection too. So We always worry about people stopping their steroids abruptly. So you always make sure, listen, we have to taper the patient. So an abrupt cessation of steroid use, you develop secondary adrenal insufficiency. Now, we can also have a tertiary, which I read at the bottom. If the hypothalamus decided not to produce CRH, which is what? Corticotropin releasing hormone, right? And telling the pituitary to make ACTH, an adrenocorticotropic hormone, which is not going to tell the adrenals, make some cortisol. Guess what? You're going to get adrenal insufficiency, but this is very rare. So you think I'm going to sit here and mumble and cry over it? No! I just wanted to let you know for completion's sake. Now, clinical features of primary adrenal insufficiency is going to become almost different from what? Secondary, and there's a reason. See, when you have a secondary adrenal insufficiency, you don't make cortisol. You still make aldosterone, because aldosterone doesn't really depend on ACTH as much, right? However, if I knock out the entire gland, if the entire gland is knocked out, right, bam, both cortisol and aldosterone are not going to be available. So now let's talk about the features that we're going to see in patients with primary symptoms. If it's a primary, and in this case, we don't have aldosterone or cortisol, all right, we don't have to memorize this. This is pretty straightforward. They're going to have low aldosterone. And we can basically talk about what the symptoms are going to be. If I don't have aldosterone, wait a minute, I can't reabsorb back the sodium. If I can't reabsorb the sodium, I'm going to keep losing it. So if I lose it, I develop hyponatremia. And guess what? That's an opportunity for potassium to go in, because sodium ATPase pump is not working. Sodium is going to get lost and potassium is going to come in. I develop elevated amount of what? Potassium. But because I'm losing all my salts, guess what the water is going to do? The water is just going to follow, and we're going to develop hypo. I like to put my hypo like that, right? Volemia. They're going to develop hypovolemia, right? Decrease intravascular volume. Guess what? That's going to decrease renal perfusion, obviously. And if I develop hypotension from what? I'm going to develop what? I'm sorry. Hypertension from hypovolemia. Hypotension. Right? My blood pressure is going to do what? It's going to drop. What's going to happen to my cardiac output? It's going to drop. What's going to happen to my perfusion to my brain? It's going to drop. So, can you see how this is serious? My renal perfusion is also going to what? It's going to drop. So, but what exactly? Hyperkalemia can cause what? Weakness, fatigue. It can cause arrhythmias too. So that's serious. If I have an elevated amount of potassium up to the point it's so elevated, it can come with arrhythmias. So you got to watch out for that. Now, decreased cardiac output, what did I say? You're going to develop shock, right? Hypovolemic shock, decreased perfusion to the brain. Now, you can pass out, right? You go syncope. Very easy. I don't have enough blood pressure, I pass out. Well, that is the case of primary adrenal insufficiency. And remember, I don't have cortisol. So if I don't have cortisol, I can't even mount a response to stress. Let's see what happens if our friend, little Joe, decides to stop taking his prednisone. Before I move on to secondary, because this is excruciatingly important, if I can't make any cortisol and I don't make any aldosterone because I knocked out the gland, what's going to happen to my ACTH? It's going to be what? Very high. Are we clear? Right? ACTH in this case is very high in primary. High ACTH. And we're going to talk about this in the diagnosis. But there might be a symptoms you might see in this patient, because when these patients have primary adrenal insufficiency, what's going to happen? They're going to have elevated amount of what? MSH, which is melanocyte stimulating hormone, right? Stimulating hormone. That's going to cause this patient to become what? Hyperpigmentation. So in patients with primary hyperaldosteronism, right, they're going to have hyperpigmentation and hyperkalemia. Remember, they're hyperkalemic because they don't have any aldosterone. Very, very important. Now, let's go ahead and talk about secondary hyperaldosteronism. I'm sorry, why do I keep saying that? Secondary adrenal insufficiency. In this case, we don't have cortisol. So the symptoms, let's erase this. The clinical symptoms are going to be what? So if we don't have any cortisol, if I have a stress in my life, an infection, a trauma, cortisol is normally a gluconeogenic hormone. If I can produce glucose through gluconeogenesis, what's going to happen to my blood glucose? I'm going to become hypoglycemic. They develop hypoglycemia. However, they're going to have hypertension, orthostatic hypertension, because they still have aldosterone. However, the blood pressure is still going to be a little bit high because aldosterone is still being produced. The only problem is they don't have cortisol. Also, what you need to know is they have GI symptoms like anorexia, vague abdominal pain, nausea, vomiting. These are kind of like non-specific symptoms just because they don't have cortisol. Well, they might develop CNS symptoms, become lethargic, okay? They also develop confusion and psychosis. All because they don't have their cortisol level. Now, the difference though is in this case, the ACTH level is going to be low because they're taking the steroid. So we're going to go ahead and figure out exactly how we make the diagnosis of this patient. How do we make the diagnosis? We've pretty much been talking about it. The first thing you want to check is check their cortisol level. So let's check cortisol level. And let's break that into two. If their cortisol level is low, right? The cortisol level is low, well, that means the adrenal gland is not making any cortisol. Now, we also want to check for their plasma ACTH level. If the cortisol level is low, that's telling us that it's either the adrenal gland is not making any cortisol or the pituitary gland is not making any cortisol. But the only way we can find out is to do what? Let's check their ACTH level, right? If we check ACTH, and the ACTH level is what? It's low. Or the ACTH level is high, that's telling us two different things. If it's a primary adrenal insufficiency, whereby this is actually already knocked out by either by TB or what, by autoimmune like Addison's disease, what do you think is going to happen to the ACTH level? It's going to be what? Very, very high. So this might be telling us this might be a primary, because ACTH level is going to be very high, trying to stimulate this dead adrenal gland. But if ACTH level is low, that's telling us it's what? It's a secondary process. So there's a test we order called the standard ACTH test. We give the patient ACTH. If I give you ACTH and you have a primary deficiency, what do you think is going to happen to your cortisol level? Well, the adrenal gland is not working, right? So if I give you ACTH stimulation test, which is one of the tests we are going to order, ACTH stimulation test. If I give you ACTH and it gets there and the adrenal gland is dead because TB ate it up, cancer ate it up, we took it out, or autoimmune destruction of the gland, what's going to happen to our cortisol level? Ooh, 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 ooh. It's not going to be high. No. But in secondary, where you've been taking this pill for so long, if I still give you ACTH stimulation test, guess what? By IV, you're still not going to get a response. You know why? Because the adrenals are just used to not being stimulated. So they're going to be like, but they might hear somebody knock on the door, but they're not going to open it like, oh, we haven't heard that in a long time. But if you try it 5 to 6 days later, you're like, okay, that's the second knock. Guess what? If I give it to you 4 to 5 days later, cortisol level will be back up again. In that case, you have secondary adrenal insufficiency. This is the definite test you want to always order. So remember, if you check for, if you always check, you always know that the plasma cortisol level is going to be low, right? Because that's usually what the problem is. If it's high, we've got Cushing's or some kind of Cushing syndrome. If it's low, we gotta order ACTH levels. And ACTH level, if it's low, that's telling us, wait a minute, ACTH is not being made. That's supposed to be made by the pituitary gland. That means that's a secondary adrenal insufficiency, right? It's needed. We've been taking the steroid for so long. Or if it's primary, in this case, ACTH will be high because the gland is dead. Something ate it up. We took it out. Autoimmune destruction, something, and thus that level is going to be high. ACTH, we're going to keep trying to stimulate this dead organ, but it's not going to wake up. And we're going to have to do an ACTH stimulation, which is definitely going to tell us, wait a minute, let's see if the adrenal gland is working. You give the ACTH and the adrenal gland doesn't respond, guess what? It's primary. If we give it today and we're like, you know, we'll try again in 5 days. You come back in 5 days and we give it to you again. The cortisol level is like, ooh, you're like, ah, look at that. The first knock, you did not want to open the door. But guess what? I tried to knock again and you did open the door. So what do we want to do? You can also perform an imaging test, because in endocrinology, we always want to do all the stimulate. We stimulate you a little bit and then we take a picture. Stimulate and we take a picture. So we do an imaging and we can order an MRI, or we can also of the brain to make sure you don't have something wrong inside your brain. If something is wrong inside the brain, if you have a craniopharyngioma or prolactinoma encroaching on it, causing us to be able to make ACTH or something like that, or something destroying the pituitary, probably you're going to see it on MRI. And if it's hypothalamic, they'll pick it up on MRI also. So how do we treat? Right? We're not going to send you home without getting treated. Treatment. Well, in treatment, what do we do? Well, if it's primary adrenal insufficiency, right? We don't have cortisol and we don't have what? We don't have aldosterone. So what we're going to give you? We give you both of them back. We give you a glucocorticoid called prednisone. And we also give you what? Fludrocortisone. This acts as a mineralocorticoid, just like aldosterone. Exactly. And this acts like cortisol, which is a gluconeogenic hormone, or glucocorticoids, which will be cortisol. We give you both, and guess what? You're back. You have to take it daily, and you should be okay. And if it's secondary, don't ever stop it abruptly. You titrate them slowly, day in, day out, until their cortisol level start to rise back up, because as the prednisone levels start to drop, and you drop it every week, eventually the adrenal gland's like, wait a minute, we better start making more cortisol because it seems like we're not getting enough for the body. All right? Okay. And that brings us to the end of our lecture. And I hope you really enjoyed and understand adrenal insufficiency, both the primary form and the secondary form, and what is the most common cause today by far. The secondary cause of adrenal insufficiency, not Addison's, which is common, but it's not as common as people taking steroids who stop it abruptly and they come in lethargic, confused abdominal pain, and we're like, wait a minute, you stop taking your steroids? Don't do that again. All right, till I see you again next time. I hope you enjoyed this lecture. Have a great day. Take care. Bye bye.